The next speaker is Dr. Ambrish Satwik. He is a very terrific vascular surgeon from New Delhi. He also is a great academician, and also he has many more hobbies, which are not, he's a very good writer, he's a very good speaker, and many more things to his personality. So let's listen to him on mastering suture-based closure devices, because this is a session dedicated to groin complication and limb ischemia. Ambrish, you have the next 12 minutes.
Thank you. I hope I'm audible. I'm going to be speaking very briefly on suture-based closure devices, actually just one suture-based closure device which is available in our country and which we use quite prolifically. And, as a surgeon, I'm primarily a vascular surgeon, trained as a general surgeon to begin with. And therefore, whenever I see a hole in the artery, I don't like the idea of sort of closing it only. I would rather repair the hole. And I think the process starts with first identifying the correct spot to puncture the artery, as has been described earlier. And the best way of doing that is obviously to have a mid-femoral head puncture. So always place your needle or any radiopaque object to identify the mid-femoral head and make sure that you're puncturing it. And this is just distal to the inguinal ligament. And it's equally important that the point of puncture should have bone posterior to it, because any puncture is going to be compressed against a bone. If you're puncturing either the superficial femoral artery or a point above proximal to the inguinal ligament, you'll end up in an area which has no bone posterior to the puncture site for compression. So we do all our punctures under ultrasound guidance. This has decreased our complication rates dramatically. This is to make sure that you're puncturing the anterior wall and not the lateral wall. Also to make sure that there is no plaque, atheroma, or calcification at the site of puncture. And this is of great importance while closing the vessel with a suture-based device, as I shall demonstrate slowly. This is a real case. I mean, this is a 6 French puncture which manifested with a very large pseudoaneurysm, which wasn't taken care of. This is, she came to us, the index procedure had been done somewhere else. And look at that massive, swirling, scary pseudoaneurysm. This is just a 6 French puncture. And this is a surgical repair of this case. It's almost like doing a cesarean section, as you will notice. You can see that's, so what we've done here is kept a balloon from the other side at the site of puncture. And once we have made sure that the balloon is at the site of the rent in the vessel, this is the mural thrombus in the pseudoaneurysm sac, and then we identify the puncture site and repair it surgically. So these kind of catastrophic outcomes can be prevented just with a little bit of care and using the right closure device. So this, to my mind, is actually a marvel of industrial design, because it provides a very creative and innovative solution to closing the point of puncture. Now, pay no attention to those who are not familiar with this device. Pay no attention to the busy slide. What's important is that the device goes inside the vessel, and if you can see my cursor, you are in a position to actually deploy a foot which is opposed to the anterior surface of the vessel. And this can be deployed by this lever, and I'm going to demonstrate how. So this suture-based closure device can be used for a sheath diameter of 5 French to 21 French. The indications for use suggest that if you're using a sheath which is up to 8 French, you can use a single device. But if you're upgrading it or need to use it for aortic aneurysm repair or TAVI or something else, then you need at least 2 devices, perhaps even 3. And in that case, this has to be a pre-close technique, which means that the device has to be deployed, the sutures have to be deployed before the index procedure is completed. and they can be subsequently tied and trimmed after the index procedure is completed. So this is an animation of how the suture-based device is to be applied. This is wire in the sheath comes out. We advance the closure device on this wire. You can see it comes out through a hole on the side. Subsequently, the wire is taken out. The hydrophilic black part of the device is actually pushed in, and when it's sufficiently in through this little orifice, it's called a marker orifice, you have blood coming out through the spout. This is when you deploy the lever. Number one, it's all marked 1, 2, 3, 4. First is when you deploy the, you deploy the lever. You can see blood coming out through the spout there. So you pull up the lever, this deploys the foot pedal. The important thing is to actually hold this at a 45-degree angle. Then you push down the plunger. Number two is pushing down the plunger. What happens is that needles are inserted into a link under the foot pedal. Then you take out, you pull out. Number three, you put it in the violin position, cut the suture, push it slightly in, close the lever that closes the foot pedal and also disengages the device from the suture. Now, once the black part, the hydrophilic part, is out of the skin orifice, the puncture site, you actually take the sutures. One of them has a white end, the other is completely blue. The blue is for advancing the knot on the site of the arterial puncture, and the white is for tightening the knot. Then you engage the suture puller and suture trimmer, push the knot all the way onto the puncture site, one at 45 degrees, the other at almost 90 degrees, then pull the other thread, which is for tightening the knot. And there you have it. Pull it back slightly. Now, put both of them together. Push them again, 45 degrees, and then subsequently almost at 90 degrees. Pull back the suture trimmer slightly and sever the threads. This is a close-up of how the foot pedal is deployed, and you can see, if you can see my cursor, the needles entering the link and conveying the stitch through and through. That's how you're able to have a secure knot that closes the arteriotomy puncture site. When you're using pre-close, which is for large devices, after you insert a 6 French sheath, you do the same thing, but before firing the plunger, when you elevate the lever and deploy the foot pedal, you do it at an angle. Okay, so once you've got blood, that means you're intravascular. So the first device has to be deployed at 10 o'clock and the other one at 2 o'clock. That's the only difference. The rest of the procedure is the same. The important thing is, as you can notice in this image, the 45-degree angle of deployment is absolutely crucial. If your angle is much lower, then you can see what happens to the foot pedal. There isn't adequate apposition with the anterior surface of the vessel. Also, if you're using pre-close, which means 2 of these sutures, the order of actually pushing the knot and trimming has to be in the order of deployment. If you don't do that, you end up with these lax bits of suture, which are going to affect hemostasis. This is just a live video demonstration. I mean, a recorded video demonstration. You can see that when the marker orifice is in, you will see pulsatile blood coming out through the spout. I apologize for the poor quality of the video. This was an impromptu. So that's the plunger being pulled out, violin position, sutures being cut, push it slightly back in, then once you've got the sutures coming out, the one with the white end has to be kept separate. That's going to tighten the knot. You don't have to touch that right now. Pull on the other one, which is going to advance the knot on the site of arterial puncture as you evacuate the device. Engage your suture knot pusher and knot trimmer all the way in, 45 degrees first. Hold it with the thumb. And then subsequently almost at 90 degrees. Make sure that you can feel a pulse, that you haven't taken the posterior wall of the vessel. Once you're satisfied, then this is when you tighten the knot. And finally, you take both the sutures together, engage the knot pusher, and tighten it one more time, and then trim it. So what is used is a polypropylene monofilament suture. This is actually like suturing the vessel close. Recommendations for ambulation, roughly 2 hours, but also this would depend entirely on what procedure has been done, what antiplatelet, anticoagulation, and thrombolytic regime has been administered. So just before I end, 2 slides. This is what happened, and I think Dr. Raghunandan Prasad earlier showed a case where uterine artery embolization was done and the vessel got closed. This is a paper from the Korean Journal of Vascular Surgery. This link here and the foot pedal has managed to actually engage the atheroma. They actually tried to reconstruct how their vessel got occluded. And you can see that after firing the needles into the link, this bit of atheroma actually gets disengaged. And when the suture is pulled, you've got one bit of atheroma floating freely, or at least that's moved a bit, and this large chunk is now adherent to the puncture site. And this could be responsible for causing occlusion of the vessel immediately after Perclose application. Thank you very much. I'm open to questions.
Thank you, Ambrish.